titled Differences in Cancer Treatment Between Children and Adults by Angelica Bevinetto, and Clinical Pearls in Immunosuppression Therapy for Pediatric Solid Organ Transplant Recipients by Krishna Daiya. Dr. Angelica Bevinetto is a pediatric oncology pharmacy specialist at Cohen Children's Medical Center. Her training includes a doctorate in pharmacy from the University of Rhode Island, College of Pharmacy, a PGY1 at NYU Langone, Long Island in Mineola, New York, and a PGY2 in pediatric oncology at Memorial Sloan Kettering Cancer Center in New York. Dr. Krishna Daiya is a pediatric solid organ transplant pharmacy specialist at Cohen Children's Medical Center. Dr. Daiya received her Doctor of Pharmacy degree from the University at Buffalo. She completed her PGY1 pharmacy residency at NYU Langone, Long Island in Mineola, New York, and PGY2 in pediatrics at Loma Linda University Children's Hospital. Dr. Daiya is board certified in pediatric pharmacy specialty. So before we get started, I would like to share a quick points. So for those who have technological issues during the presentation, please use the chat option to communicate with the office. Every effort will be made to assist the resolution. And for those who have questions that you would like to direct to the speaker, please use the question box or chat option. And the CE codes for the program will be provided at the end of the program. And let's get started.
Alrighty, thank you so much, Lilia, for that great introduction. So once again, my name is Angelica Bevinetto, and today I will be presenting on the differences in cancer treatment between children and adults. So this is really more towards geared to pharmacists who may not have exposure to the subspecialty to pediatric oncology, or if you're more of a pediatric pharmacist who sees the occasional oncology patient, or vice versa, you're the oncology pharmacist who sees the occasional pediatric patient. So it's really open to everyone. It's a really quick overview. And if you have any questions, my contact info will be at the end of the presentation, along with the question and answer session. And really quickly, I have no disclosures, no financial disclosures. And the outline for today will be focusing on how to determine oncologic disease states that differ between pediatrics and adults. And we'll be mostly focusing on presentation, how we are treating our kids, and how our outcomes for this population may differ from what you see with adults. And then we'll go into things that may be a little bit more specific to that pediatric population. So calculations, we'll be looking more on hydration, which for those who work in pediatrics, you'll be a little bit more familiar with, and some potentially dangerous drug-drug interactions that are unique to chemotherapy agents. So if you are more familiar in your oncology pharmacy. And again, very brief overview of these topics, and they will be applicable to everyone's practice, really. So really, as an introduction to adult versus pediatric disease states within cancer diagnostics. So to the image to the right of your screen, you can tell that all cancers, it's a very small proportion that children even get cancer, but within the pediatric population, it can be highly deadly in comparison to the disease states you may see in children. It is the second leading cause of death in children. The number one is accidents, so those motor vehicle accidents or whatnot. So it does take the place as number one for the leading cause of death for a disease state in children. You'll see within childhood cancers, the most common types of cancers we see is more of the hematologic disease states. So the leukemias, lymphomas, most common being acute lymphoblastic leukemia or ALL, with more of your solid tumors, like your brain tumors or maybe neuroblastoma, a little bit less common in comparison to adults, where you see solid tumors being more common, more like your more endocrine cancers like your breast cancer, your prostate cancer. With that, we do have less patients with these oncologic disease states. We will get into how we address that very low end in our studies. But with that, our kids do tend to be healthier when starting treatment compared to an adult who may have a little bit more comorbidities, such like diabetes, hypertension, obesity is a big one. We can see that in our pediatric population, but we just don't see it as often. So usually our kids are able to handle the toxic side effects of chemotherapy a little bit better compared to our adult counterparts. With that, we can give them more chemotherapy. We do see other kinds of cancer, and we do see a higher cure rate with our kids. So we usually have maybe a little bit happier stories in pediatrics compared to adults, because we can actually see that C word, the cure rate, with our children. Something that we do have to consider, if we do cure a pediatric oncology patient, they would have to live with being a cancer survivor for decades afterwards. So if you do cure a patient who's 10 years old, how would that affect their comorbidities when they're 30 years old, when they're 50 years old, when they're 90 years old? A good example is cardiotoxicity from chemotherapy drugs like anthracyclines, like doxorubicin. If I get that at 10 years old, how that affects my cardio risk factors when I'm, again, like 30, 40 years old. And lastly, kids can't really speak for themselves, especially our very young children. For example, a really common presentation for neuroblastoma is your toddler age or even younger. We have infants with neuroblastoma, and they can't tell mom or dad that there's something that's annoying them in their stomach. They'll just cry. What's the cry for? Maybe they'll just stop walking, but why do they stop? Why do they stop walking? Is it because of bone pain? Is it behavioral? So it's really different compared to adult who's saying, oh, I don't feel well, I have to go to the doctor. It comes upon the providers and even the patient's family to really identify something's wrong when it comes to that stage of diagnosis. So I'll be going over a couple organizations that are really good resources within the pediatric oncology world. Really, the most important is COG, which is Children's Oncology Group. It is a part of the National Cancer Institute, and there are more than 200 centers around the world that are part of COG, but it's really more, it's North America, so the US, America, and then also New Zealand and Australia. And I talked about how there's less patients in pediatric oncology, so that N in our studies is usually really low. Organizations really being COG is our epicenter for where we do most of our studies. So a child with ALL in New York will be getting treated with the same oncology protocol as a child in Canada, as a child in California, as a child in Australia. And with that, we can get a larger amount of patients enrolled onto one study. And with that, this is really where we do our experiments and our trials on protocols and treatments for pediatric disease states. So the figure shows really ALL, which we've seen drastic improvements with survival status. So you could see in even the 1970s, the disease state had really dismal outcomes. So even 20%, 10% survival outcomes. We see over a 90% survival outcome now in 2023. And that's cure rate. So we could cure this compared to it being a deadly disease not even 50 years ago. And that's really because we have one place that we could really depend on, that we could do our trials, and we can share information within this group. Some other resources as a pediatric oncology pharmacist that I like to use. First, for those who work more in the adult oncology sector, NCCN is definitely your friend for more of the adult cancers, for clinical practice guidelines. For me, I usually don't use it as much in my practice for pediatrics. It's usually when I get a pediatric patient with a rare disease that you see more often in adults. So for example, chronic myeloid leukemia or CML is very common in adults, very uncommon in pediatrics. So I will review more of your adult guidelines, see what's happening, what's our standard of care, and how that can apply to maybe like a 10-year-old. Next would be POGO, or the Pediatric Oncology Group of Ontario. I really like these guidelines that they come out. A lot of them are endorsed by COG. And for example, fibroneutropenia guidelines have been really our standard of care from POGO. And IDSA guidelines, we're all familiar with for Infectious Disease Society for clinical management of infections. It's nice to go into the guidelines and see what they say for immunocompromised patients. A good example is the C. diff guideline. The guideline will say, okay, so in an immunocompromised population, how does treatment differ? And they'll also say what to do for the pediatric population. So the IDSA does focus a lot on the immunocompromised population. So going back to COG, the very important institution that comes out with our treatment protocols, compared to adults, most of our trials will be named with a bunch of letters and numbers. So ALL 1732 compared to maybe FOLFOX, and everyone knows FOLFOX, everyone knows RCHOP, and what disease state that's for and what it treats for, and that's the standard of care, just by knowing the name for adults. For pediatrics, it's a little different. So for me, I know that the trial AALL 1732 is the standard of care that I use for children with high-risk acute lymphoblastic lymphoma. How do I know that? So each part of the protocol has a reason. So the first letter is A. It will always be A. It's a COG protocol, so we'll have an A. The next three letters is going to be the abbreviation for the disease state. So for this one, it's ALL, acute lymphoblastic leukemia. If I went and I had a Hodgkin's protocol, it would be HOD. If I had a AML protocol, AML, etc. The next would be the year study started. So for this example, the study started in 2017. If a study started this year, it would be AALL 23, and etc. Next is the study phase. So we know that studies can go from 1 to 4 or even a pilot trial. So that would be a P. So for this example, we have a phase 3 study. And then lastly, the number of the study. So if we've had a couple of different phase 3 trials for ALL in 2017, we just number them accordingly. So for this example, we do have a protocol called AALL 1731. That was the first phase 3 trial in 2017 for ALL. And then we had AALL 1732, the second phase 3 trial in 2017 for ALL. So the way I have taught it is to really read that backwards. As to why it's named that. But the way that we say it in practice is to read it from left to right, AALL 1732. And access to these protocols would be on the COG website. To speak again about the outcomes that we see in the pediatric oncology population, these are really more statistics from 2022 for pediatric oncology patients. I did say that we do see more promising prognoses with our pediatric oncology population. And really that bolded statement of 85% of children with cancer now survive 5 years or more, which is great. And we see, of course, certain disease states are better than others. So going back to the ALL, it's the most common disease state that we see in the pediatric population, and that's over 90% survival after 5 years. There are still disease states that can be deadly. They have poor outcomes, and really brain tumors are the disease states with the worst prognoses at this point in time. And within brain tumors, certain disease states are worse than others. So for diffuse midline gliomas or DIPG, it's going to be a prognosis of less than 1 year of a median survival. So we still do have a lot more to overcome when it comes to prognoses for our pediatric oncology patients, but we definitely are making strides in many disease states, especially our more hematologic focused disease states. And then again, talking more about those late effects, more than 95% of survivors will have a significant health-related issue by the time they are 45 years of age. So they'll be seeing some comorbidities maybe that they might have not experienced because of their disease state. Again, I think a good example is the anthracyclines with the cardiotoxicity, but you can also see things like hypertension, you could see things like dyslipidemia, you could see secondary malignancies. So a big proponent of what we do for our protocols right now, if we have a high success rate, a high cure rate, is we try to take away the toxicity of the protocol. So one of those examples, again, is ALL. We have a lot of risk stratification right now for ALL. So you could have an average risk patient, a standard risk patient, excuse me, versus a high risk patient. You could now say a standard risk patient gets less therapy compared to a high risk patient. So we're taking away certain medications or the potency of certain medications and still maintaining the efficacy and that cure rate for those patients who can have better outcomes. So really it is that balance between efficacy, giving them all the chemotherapy that they absolutely need to cure this disease, versus toxicity, not only the acute toxicity, maybe those infection complications and the supportive care that we see in the moment during their treatment, but also accounting for their late effects. So now the second portion of my presentation will go into chemotherapy and calculation overview. And just to introduce what is chemotherapy for those who haven't seen it in a bit. So you can see really two big sections of chemotherapy. The first being conventional, that's more of your chemical derived chemotherapies. So those will be your more cell cycle based therapies like doxorubicin, etoposide, irinotecan, vincristine, a lot of those that you probably have learned even so back as in pharmacy school. Biologics is different. These are chemotherapies derived from living organisms. These are really more of the forefront of what's coming out, what's new in cancer. And these could be biologics like colony stimulating factors like filgrastim, monoclonal antibodies like rituximab, brentuximab, interferons, and interleukins. In both of these chemotherapy sections, you will see targeted therapy. Another really big focus in drug development and what we're seeing come out for cancer therapy is targeted therapy. So for example, you'll have conventional chemotherapy that targets really just rapidly dividing cells in general. And that's why you'll see alopecia and whatnot and mucositis. Targeted therapy targets the actual cancer. They're usually targeting proteins that control how cancer cells grow, divide, and spread. A good example is imatinib for BCR-ABL mutations, for Philadelphia chromosome mutations in ALL and CML. And briefly, want to talk about staying safe and all the preparation and administration that goes into handling chemotherapy. Most of our chemotherapy medications are hazardous. In my role, a lot of what I do is determine if something's hazardous, something new that we haven't seen in a while, especially in peds. We don't see that many wacky of drugs in comparison to adults. So we get a lot of questions of, oh, I never seen this medication before. Is it hazardous? Do I have to prepare it in a certain way? And I go to the NIOSH list, and that defines hazardous drugs really being carcinogenic and tetragenic among the other things listed. With that, hazardous medications do need to be prepared as according to the USP chapter 800. And then just the image to right is summarizing the requirements. One thing that I, in my role, have been working a lot with is the closed system transfer devices and education with that. So closed system transfer devices being once the chemotherapy is prepared, all the lines that are connected, there's no possibility of the line breaking and the chemotherapy leaking. It's especially important in the pediatric population, I've learned, because my kids like to be Tarzan and swing from their lines, and they're pulling on it. They don't know what it is that's bothering them, and we definitely don't want chemotherapy spilling in that moment. Another safety issue, just in general for the pediatric oncology subspecialty, is medication safety. Chemotherapy itself has a lot of errors at about 2 to 5%, and those are usually really serious errors. And then pediatrics is really that really common area for medication errors. They happen 3 times more frequently than adult patients. So we have a high risk population with oncology and a high incidence with the pediatric population. That really culminates in this storm of a high risk group that we have to minimize the risk of errors in this population. So there has been a lot of ICMP guidance for the oncology population. One of the more popular or well-known ICMP practices is our vinca alkaloid preparation and administration. So it did stem from a error that happened in children. So in January 2019, children did receive vincristine by IT route. If you do administer vincristine by IT route, it's a slow and 100% cause of death. It's a horrible death, and there's ways that you can now prevent that risk. Vincristine is usually really low doses, like 2 milligrams. So the thought is, oh, I'm going to put in a syringe. We cannot do that now according to ICMP recommendations, best practices. We prepare it in a IV bag to pick that. So there's no way that a nurse can confuse it and put it into via IT. We also, at my institution, we do use vinca alkaloids in the bags, but we also do not administer chemotherapies at the same time. So if a patient's coming in for ifosfamide etoposide, we give the ifosfamide first completely. We make sure that's done. We make sure that's out of the room, and then we give the etoposide so that there's no mistake of which went first, how long is one going for, was the route okay, what did they react to, as a medication safety risk prevention. So along with my role, we do have staff pharmacists and clinical pharmacists at my institution at Cohen Children's. And really what I teach at my institution is reviewing orders for oncology patients that maybe our pediatric pharmacists do not see day to day. And with that, there are a lot of drug-drug interactions that occur with chemotherapy agents. So to really delve deep into one of them is methotrexate. I choose methotrexate because we do have high-dose methotrexate being administered pretty commonly at our institution, and they do stay here, our patients stay here for clearance of high-dose methotrexate. So this is an example of how the order looks on our interface. So we use Sunrise methotrexate order, and that order will be administered and will come off of the patient's profile once it's done being administered. What I train our pharmacists is to really perform chart review on your patients and see which chemotherapies this patient is planned to get and has received, because as we know, methotrexate lasts in our bodies, and high-dose methotrexate is monitored for levels until it's been cleared. So there are drug-drug interactions for methotrexate, say 2 days after high-dose methotrexate is given. And if we give a medication that has interaction, it will delay clearance of this potentially toxic medication. So some common drug-drug interactions with methotrexate that decrease clearance of methotrexate. I highlighted the big ones that I see in my practice. The first being the trimethoprim sulfamethoxazole or Bactrim. A lot of our immunocompromised kids are on PJP prophylaxis, and I would say in my group, we're pretty good about changing our kids to IV pentamidine, which is usually our second-line therapy for PJP prophylaxis during the time that we know they're going to get high-dose methotrexate. But it's something to definitely be aware of. Proton pump inhibitors is also a very common one, especially it's an over-the-counter medication. So I ask all of our patients, oh, do you have any stomach issues? Did you use anything like Prilosec or PPIs outpatient before you came in for your high-dose methotrexate treatment? NSAIDs I don't see as much in my population just because we avoid NSAIDs in our our oncologic population. We usually prefer Tylenol for pain treatment, but I do see penicillins a lot because we are, of course, dealing with a lot of infections in our immunocompromised population. So a good example of this is a patient comes in for high-dose methotrexate. Maybe a couple days later, they're still clearing. Maybe their ANC drops, and maybe they get a fever. So now we're treating neutropenic fever, which is a whole nother topic. But to spoil it, I would probably choose between cefepime or piptazo, or also called Zosyn. The piptazo is a penicillin. I wouldn't give that to a patient who still has methotrexate in their system. I would prefer to use a cephalosporin, which doesn't have the drug-drug interaction, for the treatment of the febrile neutropenia. And Lexicomp is your friend for these drug-drug interactions. And if you're not familiar with either the peds population or the oncology population or either, again, Lexicomp, just put all your medications in there. It's a great resource, of course. And lastly, I want to focus on some pediatric oncology calculations. First being hydration. So for any pediatric patient, we use the 4-2-1 rule for hydration. So if you are working with a pediatric patient and you hear something like, oh, run the fluids at maintenance, run the fluids at 2 times maintenance, this is where we get that number. So the way that we calculate the 4-2-1 rule for maintenance hydration is looking at just the example 1, the first 10 kilos of a patient, you multiply that by 4, so that'll be 40 milliliters an hour. And then if they weigh more than that, so the second 11 to 20 kilos, you multiply that by 2, so 20 milliliters an hour. And then anything else beyond that, so this patient is 66 kilos, you have 46 kilos left, you multiply that by 1. And then you add it all up. So in example 1, we added 40 plus 20 plus 46. So the total maintenance is 106 milliliters an hour. So that's 1 times maintenance. So if I have a patient come in, we start them on 1 times maintenance. Maybe I want them to get more. They haven't been drinking. They're dehydrated. I go at 2 times maintenance. So it'll be like 212 milliliters an hour. So now, in addition to the 4-2-1 rule, which is, again, a little bit more unique to pediatrics, in pediatric oncology, we also have another way to calculate hydration. So if you see a random fluid rate on a pediatric oncology patient, it's important to see how they got to that number. So it could be from the 4-2-1 rule of maintenance, or it could be based on BSA. So a lot of our oncology medications that are particularly nephrotoxic, in their protocol, they will suggest a hydration based on BSA. So again, going back to methotrexate, it's a nephrotoxic medication, and our protocols will usually start them on a hydration of 125 milliliters per meter squared per hour. And another option could be 200 milliliters per meter squared per hour. So to compare all those different ways of how to calculate hydration, going back to our first example, the 4-2-1 rule maintenance is 106 milliliters an hour. Just making up for this example, the patient's BSA was 1.76 meters squared. So the BSA-based hydration could either be 220 milliliters an hour or 350 milliliters an hour based on whichever really protocol says to do. So you get 3 different ways of a patient being properly hydrated. So it is important to, if that doesn't say in the order, to ask if the hydration is appropriate for the patient's needs. And that is all I have for today. Any questions? I do have some questions for the poll. I hope that no one saw my answer for the first one. Okay, so which of the following is true? ALL is our most common type of cancer in children, or pediatric brain tumors have the highest mortality rates. Brain tumors are the most common type of cancers in children, and pediatric ALL has the highest mortality rates. Neuroblastoma is the most common type of cancer in children. Pediatric brain tumors have the highest mortality rates, and ALL is the most common type of cancer in children. Hodgkin lymphoma has the highest mortality rates. I'll give you a couple seconds. You see that on the screen? Okay, so we have most of us answering A, which is correct. So ALL is our most common type of cancer. It also has really good outcomes versus pediatric brain tumors do have the highest mortality rates, unfortunately. Just to answer a couple of the other questions, Hodgkin's lymphoma actually has a really great prognosis in the pediatric population. And neuroblastoma can be common in pediatrics. It's very pediatric centric as a disease state, but we just don't see it as much as more of our hematologic disease states like leukemia and lymphoma. Question 2, which chapter of the USP focuses on hazardous drug preparation? So is it USP 700, 797, 800, or 850? Alrighty, so most of our answers are USP 800, which is correct. So USP 800 is focusing on hazardous prep for our medications. And our last question, question 3, which of the following medications causes delayed clearance of methotrexate due to a drug-drug interaction? A, meropenem, B, pantoprazole, C, ondansetron, or D, famotidine? I actually don't see the poll. Lily, I don't see the poll anymore, so if you could just let me know when those answers are posted. Oh, I see it now. Okay, great. So most of you did answer correctly with B, pantoprazole, because it is a PPI, proton pump inhibitor. So that would delay the clearance of methotrexate. Meropenem is not a penicillin, so wouldn't delay methotrexate clearance. Ondansetron, we give a lot of ondansetron to our patients as a 5-HT3 inhibitor for nausea that does not interact. And I threw in famotidine as of H2RA that is used for any sort of stomach ache or GERD, but that's something that we can use for methotrexate. All right.
Thank you so much, Angelica. Very nice presentation. I really appreciate all the tips and a very nice introduction to the topic. I do have one question before we move on to the next topic. Do you have any medication safety tips for pharmacists calculating chemotherapy or biotherapy doses for pediatric oncology orders?
So
audience.
Let's see. So any medication safety tips for calculation. So really my biggest tip is double verification. So really even for when I'm calculating orders, I have my oncology satellite who's double verifying my calculations. And even for when I'm doing my own day-to-day calculations that are not on the orders, so like pain medications, I always have a double check with my other clinical pharmacists. So calculations, I also for maintenance calculations, there are a lot of online resources for calculators. Just make sure that's according to really what your institution says is the formula for maintenance. So there's the 4-2-1 rule, which is what I went over today. There's also the Holiday-Seeger method for calculating maintenance in pediatrics.
Thank you so much.
Thank you, everyone. I'm going to
Thank you, everyone. So today I'll be presenting on clinical pearls and immunosuppression therapy for pediatric solid organ transplant recipients. I'm Krishna, and I'm one of the pediatric solid organ transplant pharmacists at Cohen's Children's Medical Center. I have no conflicts of interest or financial relationships to disclose. Here I've provided learning objectives for your reference. I will be reviewing induction and maintenance therapies for pediatric solid organ transplant patients, along with reviewing monitoring parameters and discussing common adverse effects we would see. I'll also be reviewing appropriate supportive care measures for preventing infections as well. Here are some abbreviations I'll be using throughout the presentation for your reference. So overall, our goals of immunosuppression therapy in our solid organ transplant recipients is to prevent acute and chronic organ rejection and to promote graft survival. There's been a significant shift in the last few years to utilize newer agents and multiple immunosuppressant agents at lower doses so that we're minimizing the number and severity of toxicities that we see commonly. Reviewing the pathophysiology, most of our immunosuppression therapies target in preventing T cell activation, as this is the common mechanism of rejection in our solid organ transplant recipients. There are three main pathways at which this occurs. So we have signal 1, which is where antigen recognition occurs in the major histocompatibility complex. And then we have signal 2, which involves in binding of the co-stimulatory molecules. Lastly, we have signal 3, where we have proliferation of T cell from amplification of cytokines. So many of our immunosuppressions actually target signals 1, 2, or 3 to prevent T cell activation. So now I'll be reviewing induction therapy. The purpose of this is to give a short course of immunosuppression therapy immediately in the post-operative period to prevent early rejection. Often these agents are very strong and potent and deplete our T cells for a long period of time, for over several months even. One thing I wanted to highlight is that not all solid organ transplants require induction therapies. So commonly we have pediatric and heart and lung kidney transplant recipients who do receive induction therapy up to anywhere from 84 to 95%. And then for our pediatric liver transplant population, only about 40% of our recipients receive induction therapy. So we have multiple different agents that we can use. We have our lymphocyte depleting agents, most commonly our anti-thymocyte globulin. We have the one that's horse-derived and rabbit-derived, and many studies have shown actual superior efficacy with our rabbit-derived anti-thymocyte globulin and prolonged graft survival, which is why most institutions throughout the nation actually utilize this as their mainstay of induction therapy. Anti-thymocyte globulin acts on T cell surface antigens and depletes CD4 lymphocytes and is often recommended in our high immunologic risk patients. We also have alemtuzumab, which is not as commonly used in our pediatric population as there's less literature and data in the pediatric population. But one thing to note with alemtuzumab, it does bind to CD52 on T cells, macrophages, natural killer cells, and causes lysis of cells. At this point, it is part of a REMS program as it has boxed warnings for infusion reactions, malignancies, and autoimmunity as well. Alemtuzumab is currently not commercially available, and it's available through a restricted distribution program. So that's something to take note of as well. Daclizumab, although I haven't shared this on the slide, I did want to mention was another agent that was previously utilized, however, has been withdrawn from the market due to safety concerns and increased risk for meningoencephalitis. And then we have our non-depleting agents, which is basiliximab, which I will go into now. So basiliximab is actually the preferred agent for patients at low immunologic risk. So this is defined as patients that don't have any donor-specific antibodies, and if they have a 0% panel reactive antibody as well. It's also recommended in patients that have a known hypersensitivity or intolerance to anti-thymocyte globulin. Basiliximab actually inhibits interleukin-2 and therefore inhibits T cell proliferation, acting on that signal 3 pathway. Basiliximab is recommended for a total of 2 doses, and it is weight-based dosing. Typically, the first dose is given in the operating room at the time of transplant, and the second dose is given on day 4 after post-transplant. Typically, basiliximab is tolerated very well. It does not require any pre-medications, and it can be administered through a central or peripheral line over 30 minutes. Anti-thymocyte globulin, as I previously mentioned, the place in therapy, this is a preferred agent in patients with high immunologic risk, and these include patients of the African American descent, if they have a greater than 0% panel reactive antibody, if they have positive donor-specific antigens, or if there's a prolonged ischemic time of greater than 24 hours. Anti-thymocyte globulin is often given for a total cumulative dose of 6 milligrams per kilo, and the way that this is divided up actually varies significantly per institutions throughout the nation. At our institution, we typically split this up over 4 courses or 4 days of therapy. Other institutions may give it as a single dose. Because it is rather an expensive medication, we try to often round to the nearest vial size of 25 milligrams. Because anti-thymocyte globulin allows for inhibition of T cell activation for a long period of time over months, we can actually delay calcineurin and initiation for our patients. So typically, because of the higher risk of infusion and hypersensitivity reactions, it's recommended to pre-medicate with diphenhydramine, acetaminophen, and methylprednisolone. We can give it through a central or peripheral line. If it's given peripherally, we do recommend adding hydrocortisone or heparin to minimize irritation. The first infusion time should be administered over a minimum of 6 hours, and if that's tolerated, subsequent doses can be given over 4 hours. And again, our monitoring parameters here would be to assess for anaphylaxis, and in which case we would want to stop the infusion. Otherwise, we can give additional pre-medications and slow down the infusion as well. And this happens again because of the release of cytokines. So anti-thymocyte globulin can cause significant leukopenia, thrombocytopenia, or neutropenia. So one thing we do is look at and assess the patient's CBC to identify if any dose adjustments need to be made. In these situations, we can dose reduce by 50% or hold therapy. And again, the most important thing here is that we still provide the total cumulative dose of 6 milligrams per kilo. And in these cases, treatment duration may be prolonged to achieve that. Going into our steroid immunosuppression therapy, steroids are used as an induction agent as well. So we tend to give higher doses of our methylprednisolone at 10 milligrams per kilo as our typical starting. And by day 3, we taper that dose to a much lower dose of 0.6 milligrams per kilo. So there are different pathways that patients may go on. So steroid continuation would be continuing prednisolone or prednisone as their maintenance immunosuppression therapy, or we have steroid withdrawal, where we would try to discontinue steroids early on after receiving their new transplant. And we often discontinue it when we have therapeutic calcineurin inhibitor concentrations. We often like to use steroid withdrawal in our patients that have a lower immunologic risk as well. And typically in our pediatric population, we want to avoid the adverse effects associated with steroids, specifically growth suppression. And we want to help promote growth in our pediatric population. Okay, so now we have our first polling question. Which of the following induction agents require pre-medication? A, basiliximab, B, anti-thymocyte globulin, C, alemtuzumab, D, A and B, or E, B and C. So it looks like most of you answered B and C, and that is correct. So now we'll go into our maintenance immunosuppression therapy. And the backbone of maintenance immunosuppression is our calcium urine inhibitors, tacrolimus and cyclosporin, plus an antimetabolite such as mycophenolate, and with or without steroids. So typically, most institutions have adapted to utilizing tacrolimus due to better side effect profile, including lower risk of nephrotoxicity as well. Oops. So spending some time into tacrolimus, typically this is our mainstay of therapy. The initial dose we typically start at is 0.05 milligrams per kilo up to 0.2 milligrams per kilo every 12 hours. So timing of initiating these therapies really depend on the response to the new graft and assessing how well it's functioning. So some of the things we look at are improvement in creatinine and calculating their new estimated GFR, and in addition to looking at their urine output as well. Spending some time looking at different dosage forms, since we are talking about the pediatric population. For patients that can swallow tablets and capsules, our immediate release capsules would be our recommended agents. But one thing to keep in mind is that for patients that are unable to swallow capsules, one thing we can do is actually open up those capsules and administer the contents sublingually as an option. However, because this is a hazardous medication, it would be important to use appropriate precautions. This would also be recommended for your older children, since if we do choose this route, it's recommended to not drink or swallow anything for at least 15 to 30 minutes. Another option we have is extemporaneous compound available that we can make with tacrolimus at a 0.5 or 1 milligram per ml concentration. And this is the route we often choose for our younger pediatric patients. Some of the challenges we run into are patients that have an enteral or G-tube, in which case we can use the extemporaneous compounded preparation, but we do recommend to pre and post flush with something like Oroplus, since tacrolimus is a hydrophobic molecule, so it tends to stick to the tubing of these G-tubes. Another newer formulation available are the tacrolimus granules or packets, which can be turned into an oral suspension. So these have been studied in the pediatric kidney, liver, and heart transplant recipients, and these are considered to be equivalent to the immediate release formulation. However, one thing to keep in mind is that the granules were shown to have higher AUCs compared to the immediate release capsule formulations. The extended release formulations have not been extensively studied in the pediatric population, specifically the Envarsus XR. This has not been commonly studied or used in our younger patients. And if we do use it, it's typically limited to our adolescent population. So now going into the common adverse effects for tacrolimus, some of the main counseling points that we provide to our patients is to monitor for diarrhea, as this can actually indicate tacrolimus toxicity, suggesting that the levels may be super therapeutic. In addition to diarrhea, another sign of toxicity can be the presence of having tremors or headaches, which can actually progress to seizures as well. So that's something we would counsel them on as well. A lot of our patients also require to go on electrolyte supplementation, such as magnesium, as tacrolimus can cause hypomagnesemia. Other common adverse effects we see are hypertension as well, and some of the more rare but long-term consequences can be diabetes and malignancy. So reviewing some of the common food and drug-drug interactions, we counsel our patients to not eat grapefruit or pomegranate as it is a CYP3A4 inhibitor and can increase the concentration of tacrolimus. Other medications such as calcium channel blockers and azoles are not absolute contraindications, but it is important that we monitor those levels more closely due to the risk of having super therapeutic concentrations. For our inducers, antibiotics such as penicillins and anti-epileptic medications would be our common agents that can decrease or lower concentrations of tacrolimus as well. So those would be some things to keep in mind if these patients are on these medications prior to transplant. So as a solid organ transplant pharmacist, one of our most important roles is performing therapeutic drug monitoring. Most institutions typically monitor trough levels, which is done 12 hours after their previous dose if they're on a Q12-hour regimen. And our goal varies significantly depending on how long it's been since their transplant. So typically it ranges from 4 to 12, and we aim for the higher side if they're immediately in the post-transplant period. A lot of literature is now leaning more towards AUC monitoring, as this is more precise for measuring tacrolimus exposure. Some studies have even suggested that AUC correlates better with clinical outcomes, including graft survival and incidence of toxicities. A common PK-based model calculator is the Bayesian estimator that many PK studies have utilized. The biggest limitation with AUC monitoring is that there is significant variability in the AUC to trough ratios. Many adult studies have suggested that the minimum AUC recommended for kidney transplant recipients is 150, whereas other pediatric studies have suggested a goal of 240. So here I've provided correlations of AUC to trough ratios based off of a pediatric PK study. But again, this varies significantly, so it can be challenging knowing which AUC to target. Our pediatric population tend to clear tacrolimus much more quickly and metabolize it quickly as well. So sometimes we have a difficult time achieving therapeutic levels. So there are various options we have in managing this. Of course, we can always increase the dose, but that can also lead to toxicities as well. Another consideration is to increase the interval to an every 8-hour interval as opposed to the traditional Q12-hour interval. Some institutions have adapted to initiating a boosting agent such as fluconazole to help increase concentrations of tacrolimus. One of the challenges with fluconazole is it can be challenging to wean off of it and still maintain those therapeutic concentrations. And another option we have is switching to an extended release formulation, which can allow for once daily dosing. So going into mycophenolate, this is our anti-metabolite. And this is also one of our mainstays of maintenance immunosuppression therapy in addition to calcineurin inhibitors. So in dosing in pediatric patients is typically 600 milligrams per meter squared twice daily. Many institutions have actually adapted to lowering this dose to 450 milligrams per meter squared twice daily, especially if they're utilizing a calcineurin inhibitor as well. We would max out to the traditional adult dose of 1,000 milligrams, and it's available as an oral suspension. One of the common side effects we see with mycophenolate mofetil is upset stomach and gastrointestinal side effects. So one consideration is to switch them to a delayed release formulation, also known as mycophenolate sodium or Myfortic. Dosing this can be challenging since it's not recommended in patients that have a BSA of less than 1.2 due to the limited strengths available. As you can see, our recommended dose is actually a little bit lower than CellCept, and it's about 400 milligrams per meter squared, typically recommended to administer an empty stomach for maximal absorption. So other considerations to make when managing side effects from mycophenolate, It can cause significant neutropenia, so an ANC of less than 1,000 or 500, or it can cause leukopenia. So in the setting of a white blood cell count of less than 3,000, we can consider decreasing the dose, typically by 50%, or in the setting of an infection, we can hold therapy. Many studies have suggested that holding or decreasing the dose of CellCept can increase the risk of rejection. And so studies have suggested adding a corticosteroid if we're holding it for greater than 1 month. Another alternative is to switch to azathioprine, especially if they're having significant GI side effects that's not managed by switching to the myfortic formulation. Some things to consider with azathioprine is that TPMT genetic testing may be indicated, as patients that have this deficiency are at a significantly higher risk for pancytopenia. Mycophenolate mofetil is also part of the REMS program because it is teratogenic and can cause embryo-fetal toxicity. I just wanted to highlight this because this is something we discuss with our caregivers and family members, even for our youngest children that are pre-pubertal age, because this is something that they might be on lifelong, and just so that they are aware of the potential side effects if they try to get pregnant in the future. So going on to our second polling question, which of the following can be considered to achieve therapeutic concentrations of tacrolimus? Initiate nafcillin to increase tacrolimus concentration, increase dose and frequency to every 8 hours, encourage patients to eat grapefruit, or switch to oral suspension formulation. For the sake of time, we can see the polling results. Perfect. So most of us answered that we would increase the dose and frequency to every 8 hours. Okay. So tacrolimus and mycophenolate do meet the NIOSH criteria for hazardous medications. Tacrolimus can increase risk of lymphomas, and mycophenolate can cause embryo-fetal toxicity. So it's important that we use the appropriate precautions, including wearing gloves. Reviewing immunizations in the pre-transplant setting, live vaccines should be administered at least 4 weeks prior to transplant, and inactivated vaccines should be administered at least 2 weeks prior to transplant. And after transplant, live vaccines are generally contraindicated. And so one of the screening tools we use is to make sure that patients are up to date with the CDC recommended vaccines prior to transplant. Inactivated vaccines may be resumed starting anywhere from 3 to 6 months after transplant. And I've listed the live vaccines for your reference. Reviewing antibiotic prophylaxis very briefly, all of our patients receive PJP prophylaxis, and the duration will vary from 6 to 12 months. The most common prophylaxis agent we use is sulfamethoxazole, trimethoprim. For patients that can't tolerate this, alternatives do include pentamidine, atovaquone, and progonil, and dapsone as well. For antifungal prophylaxis, we often use nystatin. The risk of fungal infections in the kidney transplant population is pretty low, so we tend to use a duration of about 1 month. And for CMV prophylaxis, our recommended agent is valganciclovir, anywhere from 3 to 6 months, depending on the CMV risk. So our high-risk patients are those that are donor positive, recipient negative, and will receive it for a minimum of 6 months. So now I just wanted to briefly review the role of a pediatric cell organ transplant pharmacist. One of the things we do is evaluate our patients in the pre-transplant setting, review all of the medications they're receiving to identify any drug-drug interactions. We discuss the main medications that they'll be receiving after transplant and identify any barriers to adherence as well. We also help optimize and manage induction and maintenance regimens and perform therapeutic drug monitoring. We provide extensive counseling and education, not only in the post-op setting, but also we follow them in their outpatient clinic visits as well. One of our roles is to also assist with transitioning to adulthood and For our adolescent population specifically, we try to encourage more independence. And we try to ensure that they are also aware of what medications they're taking, the indications, the dosing, and again, helping promote that independence. These are my references. And with that, I will take any questions.
Thank you so much, Krishna. Very great presentation. We have a couple of questions in the chat. The first one, how often do you monitor the therapeutic level, I assume it's for tacrolimus, when initiated and on a regular daily basis?
That's a really great question. So in the immediate post-op setting, we actually do monitor it at a minimum of a weekly basis, every one to 2 days a week. And essentially, what we notice is we are constantly making changes to the tacrolimus dosing at this point. So they do require additional monitoring. When they are in the hospital, we do check daily levels just to ensure that they're not super therapeutic. Also taking into consideration that the steady state for tacrolimus doesn't occur until at least 3 days.
Yes, perfect. Thank you so much. And the second question, I think you discussed it a little bit, but the question is coming regarding what kind of infection prophylaxis these patients are on during maintenance therapy.
Yeah, that's a great question as well. So typically we want to cover for, we give an antiviral such as valganciclovir, and this helps cover for CMV infection, and there's some activity against EBV viruses as well. We also cover for PJP prophylaxis and antifungal prophylaxis as well. So those are our big ones. And as you can imagine, most of our transplant recipients are on anywhere from 8 to 10 medications and after transplant. So it's definitely challenging for them to stay adherent and organize all of that.
All right, thank you so much. Well, we're gonna wrap up. Thank you very much, Dr. Bevinetto and Dr. Daiya, for providing today's webinar. I would like to ask to stop recording this session so we can provide the CE codes.